Hello, and welcome to our webinar on LSVT LOUD and LSVT BIG. My name is Beth Peterson, and I'm joined by my colleague Heather Cianci, and we'll be presenting tonight or today on this topic. So our official title for this webinar is What are LSVT LOUD and LSVT BIG? And this will be an introduction to these two LSVT therapies for Parkinson's disease and also have applications to other neurological conditions as well. So we're very excited to be here today and have you join us, and we'll go ahead and just jump right in. So in terms of the plan for the webinar, first I'll go over some logistics, and then Heather and I will do a presentation of the content that we have prepared for you today. Then we'll spend some time towards the end of the webinar to make sure that we can address any questions that you may have from the audience. And at the very end of the webinar, once you X out of your screen, a survey will automatically pop up. It should take 5 minutes or less to complete. We do appreciate if you can take that survey. It really helps us with our future planning to know what we're doing well, what we can improve on, to make sure that we're doing the best we can for these webinars and really making sure that they're tailored to people that are viewing them. So we'd love your opinions and feedback on that survey at the end of the webinar. So in terms of logistics, just to let you know, right now, everyone in the audience, your microphone is automatically muted. That's just to make sure that we don't have background noise from the various environments where you may be joining us. But if you do have a question during the webinar, and especially at that Q&A part at the end, there's a few ways you can ask your questions. The first is to type in your question, and you can do that by clicking on the question box on your webinar control panel. Then I'll see the question typed in and I'll ask it out loud to the group, and either Heather or myself will respond to that. You can also raise your hand, and you can do that by clicking on the hand icon on your webinar control panel. Then I'll see that there's a hand raised, and I'll call out your first and last name to let you know that I'm unmuting your microphone. And then you can ask your question out loud to the group. And the third way, this would really be at any time. You can always email us info as in information, so info@lsvtglobal.com, and we can either respond back to you or call you if it's better to address over the phone, but we're happy to take questions after the webinar as well. So in terms of instructor biographies, I won't go into great depth here, but I just want to let you know that you have this in your handout. And I am a speech language pathologist, and my colleague Heather is a physical therapist. So I'm on the LSVT LOUD training and certification faculty side, and she's on the LSVT BIG training and certification faculty side. And in regards to the handout, sorry, I meant to mention that on the last slide, you should have received an email with the handout of the slideshow here today. That should have been sent a few hours before the webinar. I also have it uploaded to the webinar, so in your webinar control panel, you should see a tab that says handouts, and if you click on that link under handouts, then you can access that handout on your computer as well and print it off if you would like to. If for some reason you didn't get the handout, we can certainly email it to you after the webinar as well, so you have that for your records. All right, in terms of disclosures, so all LSVT faculty, so myself and Heather included, have both financial and non-financial relationships with LSVT Global. The non-financial relationships include a preference for LSVT BIG and LSVT LOUD as treatment techniques. And our financial relationships include that I'm an employee of LSVT Global and I receive lecture honorarium and travel reimbursement. Heather is a consultant for LSVT Global and receives lecture honorarium, consulting fees, and travel reimbursement. In terms of continuing education activity, so this webinar is not ASHA or state registered for CEUs, for speech, physical, or occupational therapy professionals, but it may be used for self-reported CEU credit, so as a non-registered or non-pre-approved CEU activity. So if you are a speech, physical, or occupational therapist and you would like to self-report your activity, you can just email us, so webinars@lsvtglobal.com, and you can request a certificate of attendance today. And that will include your name, the date, the duration of the webinar, so that you have that for your records. And so you'll just need to retain that certificate so that you have that in the future if you need it for your state or national association. In order to get a certificate, you will have to be in attendance for the full hour. In terms of learning objectives here today, so we hope that by the end of the presentation, you'll be able to describe the need for effective speech, physical, and occupational therapy interventions for Parkinson's. Also be able to discuss the development and data on the efficacious treatments, so both LSVT LOUD and LSVT BIG. We hope you'll be able to discuss LSVT LOUD and LSVT BIG treatment concepts, and then explain how clients can find an LSVT LOUD and or an LSVT BIG certified clinician, and then also how speech, physical, and occupational therapy professionals can receive training in these treatment approaches to become certified to deliver LSVT LOUD or LSVT BIG in their communities. So with Parkinson's disease, currently the statistics or the numbers show us that there's about 8 million people worldwide that are living with Parkinson's disease. And that number of people with the disease is expected to double by the year 2040. So in 20 years, we expect it to go up to 16 million. Our mission here at LSVT Global is to empower people with Parkinson's and also other neurological conditions to restore and maintain their highest levels of function with communication, mobility, their independence in their daily life through scientifically supported therapy programs. And again, we'll get into that research here today so you can see the science behind these programs. So we have LSVT LOUD, which is the speech therapy approach, and then we have LSVT BIG, which can be delivered by a physical or occupational therapist. It can also be done in conjunction, so you can have a physical and occupational therapist work together with a client with LSVT BIG. And we like to say that it's really a stunning time to be in rehabilitation today. So we've seen that basic science evidence for that value of exercise, whether it's exercising the voice or the body through mobility, in Parkinson's has been established. In the past, it was classically done through medication, so pharmacological treatments, possibly surgery or some combination of both of them. And it's not to say that those aren't valuable, because they certainly are, but we are seeing that value and that power of exercise really putting square in the arena of these other types of treatments that are available for Parkinson's. So there's been key principles of exercise that drive activity-dependent neuroplasticity, and those have really been identified, and we see those through the treatment programs, and we'll discuss those throughout the presentation today so you can see some of those key principles that are needed in a treatment approach to really make those effects after treatment and have those effects last over time. We've seen that exercise can improve brain functioning, and we call that neuroplasticity, or actually changes at the level of the brain. So not only are we seeing improvements behaviorally, whether that's improvements in vocal loudness and overall communication, or physically with mobility and balance, but we're also seeing changes at the level of the brain in these treatment approaches. And this may also potentially slow symptom progression, and that's really, really exciting when you're facing a neurodegenerative disease. So we like to say that exercise truly is medicine. And this is just another way to look at what we were talking about on the previous slide. So rehabilitation, the combination or any of these speech, physical, or occupational therapy, they're really becoming routine part of management in Parkinson's. And that's really a dream of ours, is that when a client is first diagnosed with Parkinson's, we of course want to see them on the best medical routine and regimen that they can get on, whether that is the medications in combination with the surgery or some type of combination there. But we also want them referred out for speech, physical, and occupational therapy so that we can get to patients as soon as possible and catch them as soon as possible, so that we don't wait until they're progressed so far that it's much harder to make the gains that we could early on in the diagnosis of Parkinson's. So we really want to empower patients through these speech, physical, and occupational therapy programs to let them know they can do something to help take control of these aspects that may be falling because of the Parkinson's disease and what it's doing to their body and their speech. So I'm going to show you a video of a woman. This was before and after LSVT LOUD. Her name is Shirley. At the time of the video, she was 59 years old. This was 2.5 years after her diagnosis. And you'll notice some changes in her voice and speech that she discusses in the video. And then I hope you also notice some changes post-treatment that you'll see, because you'll see her both before and after. In both videos, she's on her medications, the same medication dosage both before and after, and she's on her on cycle. And she has no changes in medication across these pre and post videos. And this was after 4 weeks of treatment, or that intensive 1-month speech therapy program with LSVT LOUD. So I'm going to go ahead and play Shirley here for you.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Uh-huh. Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can.
Ah.
Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes.
Because?
Because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Until I get mad and then yell.
Take a deep breath and say ah for as long as you can. Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh, yes.
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of the Pioneers one of these days with my voice.
Good for you. That's excellent. What practicing do you do at home?
My ahs, my highs, and my lows. And I read out the mail out loud.
Excellent. Do you feel like practicing helps?
Oh, yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "What? I can't hear you."
Good for you.
But I think he does that just to be cute.
I think he does too. Has anyone commented that it's easier to understand you now?
Oh, yes, I set some of our friends back when we went to their house and I talked loud. Lou says, "What the hell happened to you?" My daughter said, "Oh, Ma, that's you?"
Isn't that good? Don't you feel wonderful?
Oh, yeah, because now she can't say, "I didn't understand what you said."
Right? No excuses, right?
Yeah,
That's
no
right.
excuses.
All right. So what do you do when you want to be as easy to understand as possible?
Think loud.
All right, so I hope with that video you could see some pretty dramatic changes from pre to post treatment with Shirley there. So some things that clinicians point out when we show them that video is they definitely hear the change in loudness. You can hear that from pre to post, and then changes in vocal quality and just overall communication. And for me and for a lot of people when they see this video, the big thing that really stands out is not only do you see those changes in her vocal loudness and quality and clarity of communication, but you also see this huge jump in confidence, and you see that she seems happier. Her face is more lit up. She has a big smile on her face. She has that confidence to go out and communicate, and so we can really make a huge difference in the quality of life for these individuals that we're treating with LSVT Loud. This video is still inspiring to me no matter how many times that I see it. It's because of that confidence and that joy that we see post-treatment. So next I'm going to show another video. And this is going to be a gentleman before and after LSVT BIG. So again, the physical and occupational therapy approach. He was 71 years old at the time of this video, and it's 14 years since his diagnosis. He was referred to physical therapy for slowness, difficulty walking, falls, and freezing. And his Parkinson's medications were optimized before starting LSVT BIG. He also did not have a change in medication from before to after treatment. So you'll see him on the same type of medication before and after in the video here. And he did that intensive 1 month of LSVT BIG. So we'll go ahead and look at his video. This video doesn't have sound, so if you don't hear anything, it's not something on your end or the webinar, it's just this video doesn't have any sound. And this is going to be a side-by-side video where you'll see him pre and then compared to him, how he does post LSVT BIG. Okay, so in that video, I also hope you could see some of the dramatic changes pre to post for him. You know, the first video pre-treatment, you see him, he's walking with a cone. He has those short shuffled gait there. The second video, you see those longer strides. He's much faster with his walking. Pre-Bernie is just still on his way to the car, still getting out the door, and post-Bernie is doing circles around the parking lot. So again, a really big difference from pre to post treatment after that intensive month of LSVT BIG. All right, so we want to talk a little bit about where we began. So this is a picture of Mrs. Lee Silverman, who's the inspiration for the treatment. So LSVT LOUD, or LSVT, stands for the Lee Silverman Voice Treatment, and it was named after this woman here. And her family said, if only we can hear and understand her. So even though there were other complications as a result of the Parkinson's, she was in a wheelchair, you know, she had some health problems associated with Parkinson's, but really what her family wanted to focus on was we want to be able to understand her, hear and understand her. And so that's where LSVT LOUD was born. So they decided to create a treatment, or try to create a treatment to see if we could work on the communication aspects of Parkinson's. So we know that 89% of people with Parkinson's disease may suffer from voice and speech disorders. And so this may be reduced vocal loudness. There may be some hoarseness in the vocal quality, a monotone voice, so just the same pitch rather than a pitch variance, and then also maybe some imprecise articulation. And this picture that you see here with a quote under it is from a woman who has Parkinson's. If I have no voice, I have no life. So it can make that much of an impact on a person. If you aren't able to communicate and get your ideas heard by others, it can have a huge impact on your quality of life. So that's a big inspiration of why we want treatment to work for these individuals. If we think about the mobility side of it, we see that 68% of people with Parkinson's disease fall each year. And people with Parkinson's have 2 times greater risk for falling than community dwelling older people. So that the falls, gait impairment, and postural instability can lead to an increased risk of mortality and morbidity and contribute to depression and decreased quality of life. And too often, people with Parkinson's are not referred to physical or occupational therapy until they actually start falling. And so that's what I was referring to earlier. When a patient is diagnosed, our hope is that right upon diagnosis, whether we see these overt changes in speech or mobility, we want them referred for speech and physical or occupational therapy right away so we can get in there before we have these changes that are really impacting their quality of life, such as falling. We want them before they're falling so we can maintain where they are as best as we can, or even improve them beyond that level rather than waiting until they're at a level that it makes it much more difficult to see some dramatic improvements there. So classic medical treatments alone do not consistently or significantly improve speech, balance, or lessen falls in Parkinson's. So while we have made great strides in the medical world in terms of the treatments that are offered, whether it's pharmacological, so in the form of drugs, or deep brain stimulation in terms of helping some of the symptoms of Parkinson's, we're not seeing that they are consistently or significantly improving that speech, balance, or lessening the falls in Parkinson's. So for that, we still need to do targeted exercise. So that intensive treatment to work on those areas that aren't responding well to the medications or the surgeries. We know that Parkinson's disease is a complex disease. So there's both motor symptoms and non-motor symptoms. So in terms of the motor symptoms, the big ones we have are bradykinesia, so that slowness of movement, or hypokinesia, small movement, rigidity, and also tremor. So those are some of the cardinal signs of Parkinson's in terms of the motor symptoms. But on top of that, we also have non-motor symptoms. So higher rates of depression, neuropsychological changes, sensory changes. There might be some emotional changes along with the diagnosis, some anxiety or feelings of apathy, not caring as much anymore, potentially higher rates of dementia, autonomic dysfunction, sleep disorders. So with both treatment approaches, if we only treat these motor symptoms, then we might not make a lasting effect on the individual if we're not also targeting those non-motor symptoms to really make the biggest impact of treating the whole person with Parkinson's, whether it's the voice treatment or the physical and occupational therapy approach. So that's something to keep in mind. We want to treat it all through this treatment to make sure that we can really get in there and make the biggest difference we can and make that change last over time. So that hypokinesia, smallness of movement, affects both speech and movement. So we see that progressive decrease in loudness of speech, or what we call hypophonia, so that reduction in volume. A progressive decrease in amplitude of handwriting, which is called micrographia. A progressive shortening of stride length and arm swing during walking. So you may have seen that in Bernie in his pre-video that you saw. And then a progressive decrease in speed and amplitude duration with repetitive movements of the fingers or limbs. So this is all the ways that hypokinesia can affect the whole body of a person through both speech and movement. And we'll see with LSVT LOUD and LSVT BIG, we have parallel key concepts between both treatment approaches. So the first key concept is that target, and that target is amplitude. So with LSVT LOUD, we're focusing on loudness, so improving the amplitude through loudness. With LSVT BIG, you may have guessed we're focusing on bigness, or making those movements bigger. So with Parkinson's, the voice, we see that voice is too soft. We see the movements are too small. With that soft voice, we're trying just through that target of loudness, that single target, we're activating changes across the entire motor speech system. So you see the image on the left is someone with that soft speech, and you can see kind of everything. And I know this is just a graphic, but this really represents what we see in a Parkinson's individual. That soft speech, everything is kind of closed up more. And then when they speak with that loud voice, we see everything open up more. You can see the respiratory system improving, you know, even sitting up more straight. The mouth is more open, the articulators are moving more, and out comes louder, more intelligible speech. And so with Shirley, the woman you saw, the only focus of treatment was on vocal loudness, but we could see changes with her across the entire speech production system just with that focus on loudness. So then the parallel to that with LSVT BIG is you may see those small shuffling steps like we did with Bernie. And so with him, just working on that bigness of movement, so with the arm swing, with the leg movement, just focusing on big as that amplitude, we can see those big changes with him as well, and other individuals that are treated with LSVT BIG, with, again, just that single target of focusing on bigness, and we get to these much bigger movements. And a key that I want to mention with both of these is even though we're getting patients louder and having them move bigger, these are going to be within normal limits. So even though it's louder for the patient, it's not going to be a voice that's overly loud. Even though the movements are bigger for the patient, it's not movements that are overly big and will make them stand out. We're getting patients to within normal limits, whether it's with loudness or with the bigness. The mode of delivery is both intensive and high effort. So it's intensity across sessions, and we have this minimum dosage for efficacy. So treatment needs to be done the way it was done in the research, and that was 4 days a week for 4 weeks in a row. So 16 sessions in 1 month's time. Each session needs to be 60 minutes in duration, and the therapy does need to be done individually. So one-on-one with either the speech pathologist or the physical or occupational therapist. So it can't be done in a group because the treatment has to be so individualized to the patient to make sure we're meeting the patient's goals and encouraging them the way they need to be. We'll talk a little bit after treatment how you can certainly continue practicing in a group, but it's really important that during the month of treatment that it is individual therapy one-on-one with the professional. So there's also daily homework practice and daily carryover exercises. not just on the days when a client has therapy, but all 30 days of the month. And it must be delivered by an LSVT BIG certified physical or occupational therapist, or an LSVT LOUD certified speech therapist. So a clinician, in order to deliver the treatment, must attend either a 2-day in-person workshop or take an online course that has the same information presented to become certified in the treatment, so that they understand the background, the research, the methods of the treatment, to make sure that it's delivered the same way that it was done in the research studies, which show this huge impact. And we want to make a lifelong habit of practice for our patients. So we have this month of treatment, but if they stop right after treatment, then we can't expect those gains that they made to maintain. So it's important to help patients get in the habit of practicing every single day for the rest of their life after treatment concludes. The third key concept for both treatment approaches is calibration, and this addresses barriers to generalization. So there is a sensory disorder in Parkinson's, and so people with Parkinson's have soft speech, but they think it's within normal limits. So oftentimes with our patients, we'll hear them say, "Oh, it's not me, my husband needs a hearing aid," or, you know, my colleague needs a hearing aid, it's not me. And then the same way, thinking about the movements, they have smaller or slower movements, but they don't recognize how small or slow those movements are. "Oh, my wife just started walking faster," or whatever it may be. So there's a mismatch in how they're speaking and moving, and how they think they're speaking and moving. So that there's that sensory disorder there. There's also difficulties with internal cueing. So the physiological substrate for movement is present, but it's not being activated. So if a person with Parkinson's hears themselves on the videotape, or videotape or a video recorder, or audio recorder, if they hear their voice, they'll recognize that they're speaking too soft, but it's only in response to that external cue. The same thing with movement. If you put a mirror in front of them and show them, they would be able to recognize it, but they don't recognize it internally. So we work on that internal cueing through therapy as well, so that they know the amount of effort it takes to have that louder voice and move with those bigger steps and bigger movement in general. Also, there might be some subtle neuropsychological changes going on, so slower thinking, slower learning, problems sustaining attention or shifting cognitive set, difficulties with internal cueing, and problems in procedural memory. So that's part of the reason that treatment is focused on so simple, just focused on loudness or focused on bigness. And so altogether, these barriers that can get in the way of successful treatment are addressed, so that individuals going through the treatment know, again, the amount of effort it takes to have that within normal limits loudness, or that within normal limits bigness. And if we didn't address these types of barriers, then there's no way we would see the progress that we get in treatment go outside of the treatment room. So this is a really big concept, an important concept in the treatment approaches. For an LSVT LOUD treatment session, it's broken down by daily exercises for the first half of the session and hierarchy exercises for the second half. So the first half, we have our maximum duration of sustained vowel phonation, or that long, loud ah that you heard from Shirley, ah, and it's at least 15 repetitions of that. Then we have a maximum fundamental frequency range, and these we call our high and low ahs. So starting with that loud ah and either going high or low in pitch, ah, or ah, and we'll do at least 15 repetitions for each of those. And then we have what are called maximum functional speech loudness drills, or functional phrases. And we do 5 reps of 10 phrases that a patient would say every single day. So for example, what's for dinner? And we practice those phrases both in treatment and then home for homework. The second half of the session is the hierarchy exercises. And this is where we take the daily exercises and really move them into more speaking exercises that build across time. So this will be the second half of treatment. It's going to build in complexity across the 4 weeks. So in week 1, we're working on vocal loudness at the word and phrase level, progressing into sentences, longer reading such as paragraph or just continuous reading. And then in week 4, we get to conversation, with the end goal being that by the end of the 4 weeks of treatment, individuals have that nice loud voice, again within normal limits voice, at full conversational level. And homework, again, is assigned all 30 days, and it includes both the daily exercises and the hierarchy exercises. We also have what are called carryover exercises, and these are opportunities to use that loud voice in real life situations outside of the treatment room. They're also assigned all 30 days of the month. So those daily exercises are really the core amplitude rescaling exercises, and then the hierarchy exercises are that translation using that amplitude to functional, salient, and those individualized goals for each patient. So even though we have those ahs and those treatment exercises, the long ah, the high and low ah, the end treatment goal is not that a patient has a nice, beautiful, long, loud ah, but that end goal is that they have a louder voice in conversation, so that those daily exercises are the building blocks to get to that nice, loud voice in everyday speech. And how do we do this? We talked a little bit about calibration. So we do this through calibration training. So we're addressing that mismatch between a person's perception of their vocal loudness and how others perceive it. So again, they may think they have a soft voice, or they may have their soft voice, but they think it's within normal limits. And again, the world needs a hearing aid. And that speech within normal limits is perceived by them as too loud. So if you ask them to get louder, it may sound wonderful, but they'll say, oh, I can't talk like this. I feel like I'm shouting. So we're addressing all of these through our calibration training to make sure that the voice we train in treatment, again, walks outside the door into everyday living, into conversations with their family, with their colleagues, on the telephone, whatever it may be. So we'll talk just a little bit about the research behind LSVT LOUD. And there's been a over 30-year now journey from the invention of treatment all the way up to scale up where we are today. So beginning in 1987 was that initial invention with Lee Silverman trying to see if there was a treatment approach that could work for Parkinson's. And then we've had 3 randomized controlled trials, which are really the gold standard with evidence in treatment studies. And we'll talk a little bit about those. And then we've gone all the way up to where we are presently, which is where we're trying to train as many clinicians as possible in the treatment approaches so that they can spread this to as many patients as possible and get as many patients as possible treated to, again, improve that overall quality of life. So right now we're more in phase 4 and 5 in that clinical implementation, getting the treatment that was done in the research lab out into the real world. And so here we see some evidence for LSVT LOUD from the 3 randomized controlled trials. And the graphs that you'll see on your left here, these are changes in decibels of sound pressure level. And so that is the acoustic correlate of vocal loudness. So we're looking at vocal loudness during reading tasks. And so we see the first randomized controlled trial on the top, the second one in the middle, and the third one on the bottom. The first randomized controlled trial looked at LSVT LOUD compared to a respiratory treatment. And so we can see here, so the blue is the LSVT LOUD, and we see from pre to post that big jump, that big improvement in vocal loudness. We see a small improvement in the respiratory group, but not significant like LSVT LOUD was. And then if we go all the way out to 2 years or 24 months follow-up, we see that those gains were maintained for LSVT LOUD, but not for respiratory treatment. So those are some of the key evidence showing those statistically significant improvements both right after treatment and then maintaining that out to 2 months post-treatment. I'm sorry, 2 years post-treatment. It's not to say that the gains stopped at 2 years post-treatment. That's just when the funding for the research concluded. The second one was looking at LSVT LOUD compared to an untreated group. And so again, we see those nice changes in vocal loudness from pre to post, and then maintaining those gains out to follow-up, out to that 6-month mark in this case. And then the third randomized controlled trial was looking at LSVT LOUD compared to a group that received an articulation treatment. So instead of focusing on vocal loudness, this group was focused on over-articulating, and then also compared to a group that didn't receive treatment. And again, we see that nice jump from pre to post in vocal loudness, and maintaining that vocal loudness or those improvements out to 6 months of follow-up. So the treatments, LSVT LOUD compared to articulatory or respiratory treatment, they were matched on dosage and intensity, so they were 4 days a week for 4 weeks. They also had homework, the same 30 days each month. The therapist's enthusiasm was equal, whether the therapist was training for LSVT LOUD or LSVT Artic or a respiratory treatment. Their tasks were uncued, so patients were not given the cue of, okay, now say this in your loud voice. It was just, okay, do this reading, and then this is how they were before treatment and after treatment. So that really speaks to, this becomes their new voice after treatment. And the data was also collected by someone other than a therapist, because we know that the therapist can really become a big external cue for the patient by the end of treatment. So this was with someone other than the therapist who conducted the treatment sessions. This chart shows you LSVT LOUD patient-recorded outcomes. So this was measurements of communication effectiveness is what this measurement is looking at. And so we see the solid line is the LSVT LOUD group. Then we see the dashed line is the group that received the articulation treatment. And then the small dots are the group that was untreated. And so this is individuals rating themselves pre and post treatment in terms of overall communication effectiveness. And so we can see some nice changes here, again, improving from pre to post and maintaining those gains out to 6 months, so that patients are also perceiving and seeing that they feel that they are improving in this overall communication effectiveness. And this is a nice slide that just shows you, again, with the focus of only vocal loudness, that we see this spread of effects into many other areas related to communication. And these are the studies that have been done in other areas, such as neural imaging, so looking at changes in the brain, potential improvements in swallowing, vocal fold adduction, aerodynamics, EMG studies, so on respiration, improvements in facial expression, articulation, articulatory acoustics, some intonation, speech motor stability, and voice quality. So some really nice studies that have been done in those other areas to really show that spread of effects from loudness into these other motor speech areas. So now I'm going to go ahead and turn it over to Heather, and she's going to walk you through the translation from LSVT LOUD into LSVT BIG.
Thank you so much, Beth. That was such amazing information, and we're just so lucky that we have all of these years of wonderful research. And we as physical and occupational therapists come into this a little bit later in the game. We sort of came around 2005 when some research was initially started, where a physical therapist said, you know what, if they're doing this wonderful work with the voice speech system, making people go louder, you know, how could we translate that information and do that for the motor system, for people to be able to walk with bigger steps, to stand up with bigger posture, to be able to have an increased ability to get in and out of bed. And there was a lot of transitional research that was done between taking those highs and lows and the ahs and the different exercises that you heard Beth talk about into, you know, well, what are the exercises we should do for physical and occupational therapy for LSVT BIG. So let's move ahead to the next slide, and we'll show you a little bit about how that moved from LSVT LOUD into LSVT BIG. So you heard Beth talk about the highs and the lows, and those are kind of like the warm-ups, right? Those stepping stones to get the warm voice enriched and to get it ready for those functional phrases. Well, it's not much different with the limb motor system. We have a core group of 7 maximal daily exercises where we are pushing people through ranges of motion that might not be what they thought they could do, where they didn't think they could reach as high as they could. They didn't think that they could step as large as we're having them do. So we really use those maximal daily exercises to warm people up and to understand that there is opportunity to take larger movements, and that the movements that they think that they're actually producing and feel good to them, those are actually really not the full motion that they can do. Those movements are far too small and therefore far too slow. So getting people to understand that it's safe and you're able to do these exercises really kind of gets the system stimulated. Of course, then we work on walking, and walking is something everybody needs to be able to have in their program. For people who aren't able to walk long distances, we can still work on a few steps from a bed to a wheelchair. For individuals who may be wheelchair bound, we can also translate that walking into perhaps walking the feet in the wheelchair, or perhaps actually using the arms to propel the wheelchair. Much like the functional phrases where Beth was talking about things we say every day, like what am I having for dinner, where are my car keys, we have functional component tasks, and those are meant to be 5 everyday tasks that you do all of the time. So you as the person living with Parkinson's disease help us as the therapist, whether it's a physical therapist or an occupational therapist, determine what movements you may be having some difficulty with, or what are some movements that are really critical to you being able to function the way you want to, part of your job, part of your hobbies. And we practice those with, again, that intensity, that effort, and then that large amplitude. One of the ones that we do with everyone, no matter what, is sit to stand, but also some examples here, being able to pull the keys out of the pocket, being able to use a cell phone. I have people who want to be able to, you know, just lift their glasses up from off of the bridge of their nose over to the top of their head and back down. Lots of gentlemen with difficulty with getting the wallet in and out of the pocket. So again, the therapist works with you to figure out what these things are. And then we move lastly on to the hierarchical exercises. And basically those are your really big tasks. Those are goals that you help that therapist to establish of things you want to be able to do. Examples here of the ability to be able to get up out of bed, maybe be able to play 9 holes of golf, maybe increasing the ability and safety with getting in and out of the car. You know, again, these are subjective to what you want, what are you having trouble with, and then we help to develop that with you. And we start out very easy with those, but eventually we build that complexity up over those 4 weeks of treatment, because just like LSVT LOUD, LSVT BIG is 4 times a week for 4 weeks, and we really kind of ramp up the intensity as we go so that we know that when you leave us, you're going to be able to take what you learned about giving more effort, about working harder, and about thinking bigger, and being able to apply that just to your normal everyday activities. So of course, we don't think that's enough. We assign homework as well, and that means that we're having you do those daily exercises, not as many repetitions, but we do have you performing those. You continue with your 5 functional component tasks, and of course, we continue to have you keep working on that big walking. Again, if it's a wheelchair, doing the stuff with the wheelchair. And we also give you those carryover assignments, and those are things that we want you to do outside. You know, we want you to try out your big movements and to kind of come back to us and say, hey, this is what happened. This was the experience I had, and it felt really good. So Beth, if we click on that next slide there, it shows you that we're talking about, remember, those exercises really are the building blocks. There are stepping stones to get us going into, then go ahead and click to the next one. Really the function. So we're looking at your function. We want you to be able to practice using those really big amplitude movements in any of the functional tasks that are important to you. You know, we're not going to assign things for you. We want you to tell us. These are the 7 maximal daily exercises, and you can see how they're really aimed at opening up the spine, opening up the legs, making the posture taller, really getting those arms swinging back and forth, and of course the ability to take those steps. So we have you stepping in several different directions, forward, backward, sideways, and a lot of really nice rhythmical movements to kind of open up and get you started. Next slide. So I mentioned this before, that personalized, purposeful practice. You know, you can see that first picture up there. It's someone having the ability to be able to transfer from sit to stand. That second picture, you know, people want to be able to walk outside with their families, you know, challenging terrain like walking on a beach. You know, this third picture here, the gentleman being able to continue to drive, to be able to safely get himself in and out of the car. And then we think of things that, you know, maybe we normally take for granted, the ability to put on our shoes and socks. That can be very challenging for someone with Parkinson's disease. So the simple act of being able to do that for yourself can really kind of increase your independence. And that can go for all forms of dressing. You see the picture here with doing the buttons. And then lastly, of course, you know, where do you want to be able to walk? Do you want to be able to walk outside, inside, up and down stairs? Do you want to be able to kind of climb up and down theater stairs or stadium steps, maybe to see some sort of a sporting event or watch one of your grandchildren? Again, we make sure that it's personalized to you and that it's really part of your everyday activity. Next slide. Because our goal, and Beth articulated this so beautifully today, you know, we don't have people do the ahs with the goal of being able to do an ah. The goal is that you have more functional speech. So for us, for LSVT BIG as PTs and OTs, it's really that generalization of those exercises into your functional ability of whatever you're doing. So we're showing just a little snapshot here of a picture of the rock and reach exercise, and that's where people shift their weight from front foot to back foot, and they're swinging the arms really nice rhythmically. Now, you may think, well, I don't do that in normal everyday life, but if you think about every time you're standing and reaching for something overhead, you need to be able to shift your weight forward. You need to be able to reach that arm up and the back one back to help counterbalance you. So again, we're doing these exercises for a reason to improve that functional activity. Next slide. So talking about calibration training, and again, that is what Beth talked about before, where people feel like they're not, they're talking too loud, they're shouting when we're actually making them talk correctly at the right volume. LSVT BIG also helps to address that mismatch between a person's perception of their movement, about how they feel they're moving, and then really about how others perceive it. So oftentimes people will tell me, I didn't think anything was wrong, but then all of a sudden people started saying, you're not swinging your arm, it's just hanging at your side. Or, I just started to fall behind my friends when we were walking. I couldn't keep up with everyone. So then we train the people then to make these really big, purposeful movements. And people say, I can't walk like this. People are going to think I'm crazy. I work in Philadelphia and people say, you can't walk down the streets of Philadelphia like that. You're going to get arrested. And that's where that mismatch lies, in that because the movement is so small and because the movement is so slow, if we don't overemphasize that bigness of movement, then the quality of movement doesn't get back to where it should be. It's never too big. We're training people to get that just right. So that's why we really push that calibration, because we want people to understand what needs to be done and then take it out of the clinic. Next slide. So Beth talked about some of the LSVT LOUD research. So let's say a little talk about what's going on with LSVT BIG. What do we have out there in research? This was one of our primary research studies when we were kind of translating it from LOUD into the BIG, and this was called Training BIG to Move Faster. So they applied this 4 times a week for 4 weeks into, what are things people need to be able to do? Well, reaching for objects and the ability to walk. And they found that when you get people to think bigger and when you get people to put more effort into things, they really can reach further. They really can walk faster. And in the walking, we're not making people take more steps. So it's not like that quick runaway walking. People are taking fewer steps and bigger steps. So that was really a great breakout research, because training that amplitude, so training people to think big and move big, actually improves how much bigger they walk and then how much better their ability is. Next slide. And the training really does not just enhance one part, but it really does enhance many different levels of motor output. So we really do have documentation that it crosses all sorts of systems. So we found out from the research that we have improvements in the ability to rotate the trunk, so rolling over in bed, turning to shut off the light on the end table, the stride length, so how big of a step people are taking. Again, improvements in how fast people are able to walk and to reach, the ability to have that quick reaction time. And then the scale that the physicians do, which is called the Unified Parkinson Disease Rating Scale. We've shown some great research on how that score actually improves, meaning people have less disability and more ability. Of course, balance, coordination, and the ability to actually do those normal tasks that we want to do improve. And we found that people have a lower fall risk and they're able to do multiple things at once. So really you can see that there's many levels that are enhanced by doing this one program. Next slide. This was another wonderful study. It was really pivotal about 5 years later from that first study, and this was the Berlin BIG study done in Berlin, Germany, where they looked at 3 groups. They had people doing LSVT BIG, they had people doing a generalized home exercise program, and then they had a group of individuals who were doing Nordic walking. Everybody did 4 times a week for 4 weeks, except for the folks who were doing the walking. The norm over there for that was 2 times a week for 8 weeks. So ultimately, everyone did end up with doing 16 sessions. So let's take a look at the next slide where we look at what the findings were. And what they were looking at here is that thick line are the people who were doing the home exercise program. The people with the little dotted line were the people that were doing the Nordic walking. And then that line that's at the very bottom of the graph there, that dotted line, that dashed line, that actually represents the percentage of change from the start of the program. So you can see from that middle line there, 0, the people who did the walking and the generalized exercise program made very little improvement, where the folks who did the LSVT BIG training program made some really significant improvements in all areas. Next slide. So people ask us all the time, well, you know, is there anything else that LSVT can be used for LSVT BIG or LSVT LOUD beyond Parkinson's disease? And you can see listed here on this slide for LSVT LOUD, we have some nice research in people who have Parkinson plus or atypical Parkinsonisms, people who have actually had fetal cell transplant surgery. We have people who have used it with multiple sclerosis, as well as ataxia, cerebral palsy, Down syndrome in younger children, and just in the aging population. We're really coming into more research now, some case studies and smaller projects using LSVT BIG with individuals who have had stroke. We're starting to see some nice input from that population. So still more research to go, but you can see here that we are having some nice effects in people who are living with other conditions. Next slide. So if you are interested in reading up more about the different research studies that are out there, we offer on our website very easy access to all of these references, whether you're looking for LSVT LOUD or you're looking for LSVT BIG, looking for something outside of those conditions of Parkinson's. You can see here at our blog.lsvtglobal.com/research. So take some time if you want to read more about that research and those articles. We have those prepared for you with links on the website. Next slide. So the thing about LSVT BIG and also LSVT LOUD is, you know, once you complete the program, you know, we don't just leave you. We want to make sure that you're continuing on. You know, we're with you for this journey, and we really do push to support you to have that daily, lifelong habit of performing your exercises, whether that is for LSVT LOUD or LSVT BIG. We do have DVDs or the ability to actually download the homework helpers so you can actually perform that program along with the folks on the videos. We are now training speech language pathologists in LOUD for Life and physical and occupational therapists in BIG for Life. And those are group exercise classes where you can meet with folks who have gone through the programs and work together to kind of keep your skills sharp. Those exercise classes are not covered by insurance. They are an out-of-pocket cost. As LSVT BIG and LSVT LOUD clinicians, we do recommend keeping our folks on our schedule for tune-ups. So we really do like to get people back into the clinic every 3 to 12 months to make sure that we're attacking any kind of problems that are happening, making sure that we keep people's motivation levels high, and that we keep people kind of on track for what they need to do. And the other thing we want to do is we want to promote you getting into any other kind of enjoyable activities and fitness for Parkinson's. So any kind of singing groups or other exercise groups or socialization activities. We really want to promote people having much more activity in their lives. Next slide. So if you're interested in getting started with either LSVT LOUD or LSVT BIG, you know, first and foremost, you want to talk to your doctor. And ask them for a referral or a prescription for that. And that prescription wants to say that that person is getting an evaluation and treatment. If you're looking to find someone who provides LSVT LOUD, and that would be a speech language pathologist, or looking for someone who provides LSVT BIG, and that's going to be physical therapists and occupational therapists, you can easily go to our website, and that is lsvtglobal.com. There's a nice clinician search tool option in there where you click on who you're looking for, what kind of therapist, and then type in your geographical area. It will pull up a list of all those clinicians who are certified near you. Really important to take a look though, you know, see what kind of setting that therapist is working in. If you're looking for outpatient therapy, you don't want to be contacting somebody who's providing this therapy in home health care or in inpatient rehab. If they are saying there that they're active, they're ready to go, they're in your area, we always tell people, you know, give a call, take a look, and say, hey, you know what, are you still accepting new patients? You know, what is the wait time to get in there? Can you tell me a little bit more about your organization? We do have a kind of what to ask my therapist section on the website. And there are some great questions here. And these are the 4 questions that you want to ask. You know, yes, are you currently accepting those patients? And if they're saying, yeah, we're ready to go, you want to make sure, are you really delivering the gold standard dosage? Meaning, are you doing it 4 times a week for 4 weeks? Is it one-on-one? And are you doing everything the right way? Because sometimes people will say, well, I've had LSVT LOUD, but you know, the therapist did a modified session. It was only 2 times a week. Well, we know that that's not efficacious. We know that you need to be seen for those 4 times a week for 4 weeks. The other thing is you can always ask that therapist, how many clients with Parkinson's have you treated? Because it might be someone who took the training session 2 years ago. Maybe they've only treated 1 or 2 people. They're not really comfortable with it. And you want to find out, what are your typical outcomes? How well are your patients doing? And then, when I'm done with you, what do you do for me? Do you have any follow-up programs? Are there exercise classes? How often can I come back in to see you for tune-ups? It's completely within your right to ask about this. This is your healthcare, and you want to make sure you're getting the best quality of treatment you can. Next slide. And again, we have ongoing support for all of our therapists after they've completed their certification and training. We have wonderful downloadable materials in many different languages. We actually have a video now in Japanese. We do monthly live webinars, much like the one you're attending now, but we have a whole host of pre-recorded webinars on different advanced topics from, what do I do with newly diagnosed people versus people who are in advanced stages of Parkinson's? Can you talk to me more about documentation and billing? You always have access to the LSVT faculty for any kind of questions. We also like to invite people onto our private LSVT clinician Facebook group where we have lots of good conversations. And again, we have lots of videos and tools to help people who are already certified really kind of sharpen their skills. So once they're registered and ready to go, we keep on providing help and care to those clinicians so that they can provide better care to you. Next slide. So if you are a therapist and you're thinking you want to get certified, or if you're someone living with Parkinson's and you're thinking, gosh, I wish my therapist were certified, we have 2 great ways to do this, and they are the same curriculum, same certification, and equal confidence. People can either attend the live course where it's hands-on learning, working with each other, as well as people with Parkinson's disease, and that is a 2-day training, and we have wonderful instructors who are there to give real-time feedback. Now, we know that that's a lot to ask for people to give up that time and travel and money. So we also offer the online course. So again, being able to save some cost and to make it more convenient. It's self-paced for people who need a little bit longer, but again, really fits into people's lifestyles great. So both options are offered out there for groups and students and previously certified clinicians at discounts. So for more information, please do turn to our website. Next slide. So again, we have those opportunities to learn more, so keep on top of the monthly webinars, the on-demand webinar library. Don't forget to take a look at the patient and family section, take a look at our blog and our videos. We really want people to kind of take advantage of all of this. So for more information, again, I'm going to send you back to our website. And I think now we're going to be heading into one last quote here, which I find that's really, really wonderful. We have people who give us information, and this gentleman, Jim A., said that more than 1 year later, I still continue my LSVT BIG and LSVT LOUD exercises almost daily. I have the confidence in my body to continue doing the things I love, gardening, walking with my wife, spending time with my family, traveling, and reading poetry on the radio. Parkinson's is my enemy, but thanks to LSVT programs, I will prevail. And that's what we want, empowerment and hope in the lives of our individuals living with Parkinson's disease. So right now, I'm going to turn this back over to Beth. She's going to talk to you a little bit about, again, how to ask questions, and we can stay on a few more minutes and see if we can get your questions answered. Again, if we don't get to your question today, you can always email us at a later time.
All right, thanks so much, Heather. Really appreciate that overview of LSVT BIG. So if you have any questions right now, there's a couple ways to ask them live during the presentation. You can type in your question in that question box on your webinar control panel, or you can raise your hand by clicking on the hand icon. Then we'll call out your first and last name and let you know that we're unmuting your microphone, and you can ask your question out loud to the group. If you think of a question after the webinar here today, you can always email us at info@lsvtglobal.com. So we did have one question come through, and this clinician, or sorry, I'm not sure if it's a clinician or a patient, but they want to know, is it better to do LSVT BIG or LSVT LOUD first if a patient needs both of these treatment programs? So Heather, do you want to address that question?
Yeah, that's a great one. So we always say it's up to you as the person living with Parkinson's disease. What is the one that's having the greatest impact on your life? Maybe you want to be able to do that one first. But that doesn't mean you can't do both. We have multiple people who will do an hour of LSVT Loud and then an hour of LSVT Big. And a lot of our patients do it that way. So you can do it both ways. We've had some people who are college professors who say, I need both, but right now with my job, right now, I need to be able to project that voice. I think for me, it's probably better that I start with the LSVT Loud, and then maybe over my break in the summer, I'll come back for LSVT Big. You always want to double check with your physicians to make sure you have those prescriptions, as well as double checking with your insurance carriers to make sure you're doing all the things you need to make sure that that gets covered for you.
All right, great. Thank you, Heather. We do have another question that came through. I just want to let everyone know we are at the end of our hour. So if you do need to sign off, feel free to sign off, but I do want to address this question that came through. And you can go ahead and click the X in your webinar if you want to sign off now, and then that survey will automatically pop up if you can do that survey. But we had another great question come through. So the question is, are there any concerns about vocal fold lesions or trauma with LSVT Loud? And that's a great question. And so when we are teaching clinicians how to do the treatment when they're going through the certification process, we always tell them that patients do need to receive medical clearance before beginning LSVT Loud. So the gold standard would be to have an ENT exam where an ENT or otolaryngologist is actually visualizing the vocal folds, and so that they can see if there are any contraindications to beginning LSVT Loud. At the very least, we want to have a physician cleared by either doing like a laryngeal mirror exam where at least they're visualizing the vocal folds to make sure, again, that there's no contraindications. Once we have the clear to begin treatment, then we go ahead and continue with treatment. But it is very important, so this is a great question, to get that medical clearance first before beginning treatment, because we certainly don't want to make other issues worse or begin therapy when there needs to be another treatment that should be occurring that's not LSVT Loud. There are some other issues with vocal folds that LSVT Loud would not be contraindicated for, where you could still do LSVT Loud, but it might be that you won't get the same end result that you would, for example, with vocal nodules. So you may actually improve vocal nodules with LSVT Loud, and it wouldn't be contraindicated necessarily to do it, but you may not see the same results as you would with someone who didn't have vocal nodules as well as Parkinson's disease. The big one that we're really looking for is laryngeal cancer. And if someone had laryngeal cancer, you would, of course, refer them out to get that treated right away. So that's a big reason why we do that, make sure that we do have that medical clearance. But there are some other things that are going on that you wouldn't necessarily not be able to do treatment, but it's good to know about those other conditions that are also occurring. There's also a lot of laryngeal reflex that we see in Parkinson's. So, depending on the severity of that reflex, we might wait to start treatment until that reflex is managed, because otherwise we won't be able to see the same type of progress that we could if they didn't have that irritation going on along with treatment. So that's another one that we often look for and ask ENTs to report on to see if we should wait to begin treatment and wait till they're managed on that before beginning treatment. So yes, so that's my long answer. My short answer is yes, it's important to have that physician clearance before beginning LSVT Loud to make sure there are no contraindications before beginning treatment. Okay, so I didn't see anything else come through right now, so we'll go ahead and wrap up the webinar here today. But again, feel free to contact us if you think of questions after the webinar. We're happy to address any other questions. So we want to give you a big thank you, and I want to give a big thank you to Heather. We really appreciate your time and knowledge here on the webinar today. And to the audience, we hope that you learned a lot from the webinar here and that you're able to take the survey and let us know your thoughts, and that you're also able to join us on another future webinar. So thank you, and everyone have a great rest of your day and rest of the week.